Welcome everybody to this webinar presentation. We're going to be addressing several aspects of volunteer management in disaster. This webinar will be sponsored and archived on the Department of Health and Human Services of Nebraska website. Our first speaker is Mr. Ryan Lowry, the Medical Reserve Corps and Citizen Corps Coordinator for the state of Nebraska. Ryan?
Thank you, Dr. Bowling. So I'm going to get started and talk a little bit about how the Medical Reserve Corps, which is a group of volunteer individuals who are able to assist with medical and public health disaster response incidents throughout the state. Talk a little bit about how those volunteers can integrate with our DHHS ESAR VIP system, which is the advanced registration for emergency system for advanced registration for volunteer health professionals. And so we'll go ahead and get started with how that works. The ESAR VIP and Medical Reserve Corps came together and put together a plan on how volunteers integrate within the system. That plan was revised September 2018. The purpose of this plan is to provide a framework to integrate and the activities of Nebraska's emergency system for advanced registration for volunteer health professionals with those of the Nebraska Medical Reserve Corps in support of Nebraska's disaster and emergency volunteer health and medical professionals. The Nebraska plan builds on the federal vision for the unified and systematic approach for state, local, and federal coordination of volunteer health professionals in support of existing resources to improve the health, safety, and resiliency of local communities, the state, and the nation in health and medical emergency responses. So there's two ways for Medical Reserve Corps volunteers to be activated. Traditionally, we think of volunteer activation coming from the emergency management side of things. County emergency management, local emergency management, and state emergency management all have the ability to notify and request volunteers when their resources are overwhelmed. There's also another scenario in which Medical Reserve Corps volunteers may be activated, and that's a public health emergency. So we may have an incident where there's a pandemic where it's not a natural hazard that's caused a disaster, but instead something like a pandemic where there's specified volunteers that would be needed in order to help respond, and those would be medical volunteers. And so public health does have the ability to activate Medical Reserve Corps and ESAR VIP volunteers. Generally, those requests would also be coordinated through the emergency management agency, whether it's local or state emergency management. In the state plan, in the back of the state plan, we do have an outline of how the local, regional, and state activation would occur to request ESAR VIP and Medical Reserve Corps volunteers. This is an overview of how that activation process occurs, and I'm going to just go through each section in a little more detail so that we can break that down and discuss that. And if there's any questions along the way, I'm happy to answer those. So the first is local assistance. When local resources become overwhelmed, there's a way for local emergency management or local public health departments to request those volunteers. And we always say disaster start and end locally. So your emergency manager or your public health department identifies a need, and they request the local MRC volunteers. And if those resources are adequate, then we go no further. The MRC responds, and they're able to assist with whatever natural or public health incident that they're dealing with. If those resources aren't adequate, they move to the next phase, which is regional assistance. Ideally, there are MOUs in place to assist across regions. And so in Nebraska, we have Medical Reserve Corps regions that correspond with the Healthcare Coalition regions. So we have Panhandle, we have Roamers, we have West Central, Central Nebraska, Southeast, and Tri-County, or the Omaha metro area. And those generally correspond with the Healthcare Coalition regions. So if there's a large incident in, say, the Panhandle and their MRC volunteers, they don't have enough MRC volunteers in the region to assist, they can go outside of their region and request something from, say, some help from the West Central region or maybe the Roamers region, and that's requesting that regional assistance. We can go one step further and request state assistance. Again, this is after those local and regional resources have been exhausted. The emergency manager or public health department would request additional resources, and those requests then go through the ESF 8 coordinator. And if the event is large enough, there's a good chance that that ESF 8 coordinator is positioned at or in contact with the State Emergency Operations Center at Nebraska Emergency Management Agency. So those requests go through the same process that any other equipment resource requests would normally go through for a large scale disaster. The ESAR VIP coordinator then uses a statewide notification system to notify appropriate volunteers through the ESAR VIP system. And we'll get into a little more detail about that later, about how that works. Those volunteers are notified. They're given details about the mission that they would be responding to. They're able to then respond yes or no, and then coordinate it through there. MRC volunteers who are listed in the ESAR VIP system can be selected if there's a specified need. If not, they can select non-MRC volunteers. It's really driven by the incident itself and the type of volunteer that's needed. If MRC volunteers are selected, then the state MRC coordinator, which is myself, would contact the program managers for the regions where those MRC volunteers are coming from, and make sure that they have all the additional information that they need in order to deploy. And then it follows the same process that any other resource request through the state goes through. We track the resource or the volunteer. We track their time. We ensure that they have the resources they need to do the job. And then as things wind down, we make sure that all of that information, their hours are tracked so that we can use it for whether it's FEMA reimbursement or just record keeping for ourselves. So that's really how volunteers are requested through the state at the local, regional, and state level. If there's any other questions, this is, I'm putting up Quinn Lewandowski's information because he will be taking over as the Medical Reserve Corps coordinator shortly. So if there's any questions going forward, you can contact him. His phone number and email address is available.
Thank you, Brian. Next, we are going to be talking about the emergency system for advanced registration of volunteer health professionals. Kathy Bolkovac will be presenting. Kathy.
Thank you, Denise. I'm Kathy Bolkovac, the Training and Exercise Coordinator for the State of Nebraska Public Health. And I just wanted to give you a brief overview today about the emergency system for advanced registration of volunteer health professionals, known as ESAR VIP. Thank you, Ryan, for the overview that you gave us as well. In addition to what Ryan gave, I'm going to be attaching the ESF 8 portion of, from the Nebraska State Emergency Operations Plan to the DHH website, which goes through all of those things that Ryan spoke about, and that's Appendix 7. I would also refer you to your own local emergency operations plans, which should be Annex A of everyone's local emergency operations plan, for further information about your own resources there. So what is ESAR-VIP? The Nebraska Emergency System for Advanced Registration of Volunteers and Health Professionals program is an electronic database for healthcare workers willing to volunteer to work during disasters or large-scale emergencies. It is more commonly known as a Nebraska Medical and Health Volunteer Registry. The online registration system includes verifiable, up-to-date information regarding the volunteer's identity, license, professional credentials, and privileges in hospitals or other medical facilities. The state of Nebraska owns, maintains, monitors, and secures the database. The U.S. Department of Health and Human Services requires all states to develop a system for the advanced registration of health professionals, with the ultimate goal of linking states to create a national database of potential healthcare volunteers. And with that, I just want to add that I did speak this morning to our ESAR-VIP database monitor, Kevin Kuto, and he advised me that we currently have, as of April 2018, 2,125 ESAR-VIP volunteers, and that's at all levels. So why do we need ESAR-VIP? In the wake of disasters in public health and medical emergencies, many of our nation's health professionals are eager and willing to volunteer their services. And in these times of crisis, hospitals, clinics, and temporary shelters are dependent upon the services of health professionals and volunteers. However, on such short notice, taking advantage of volunteers' time and capabilities presents a major challenge to hospital, public health, and emergency response officials. For example, immediately after the attacks of September 11th, tens of thousands of people traveled to Ground Zero in New York to volunteer and provide medical assistance. In most cases, authorities were unable to distinguish those who qualified from those who were not qualified, no matter how well-intentioned they were. There are significant problems associated with registering and verifying the credentials of health professional volunteers immediately following major disasters and emergencies. Specifically, hospitals and other facilities may be unable to verify basic licensing or credentialing information, including their training, skills, and competency levels. Further, the loss of telecommunications may prevent contact with sources that provide credential or privilege information. The goal of the ESAR-VIP program is to eliminate a number of these problems that arise when mobilizing health professional volunteers in emergency responses. After I'm finished with my presentation, I'm also going to talk a little bit about a merger that's going on, which will update the ESAR-VIP database. And Brianna Rooney will talk to you more in depth about that as well, to work some of the kinks out of these response issues and call down lists. So the ESAR-VIP mission works with states to establish a national network of state-based programs for pre-registration of volunteer health professionals. Working within this network of verified credentials and up-to-date information, volunteers are able to serve at a moment's notice within the state or across state lines to provide needed help during an emergency. So the ESAR-VIP really aims to first help health professionals, second, help health employees, and third, help state coordinators. With regard to health professionals, while volunteers are focused on the emergency at hand, it's also important that health professionals protect themselves before helping others. By registering with ESAR-VIP, health volunteers' information is recorded in a state registry, maintained and utilized in a manner consistent with all federal, state, and local laws governing security and confidentiality. With regard to helping health employers, hospitals and emergency operations are left scrambling to find qualified medical assistance in times of crisis. With the ESAR-VIP program, healthcare facilities and emergency management are able to request the help and specific skill sets they need to assist them and better serve the people in their community. State ESAR-VIP programs can then match the best volunteer candidate for the job. Specifically authorized personnel will be able to review three things: their identify and contact information, licensing information, and their credentials, training, skill levels, and competencies. And with regard to that particular thing, it's a combination of and a collaboration between NEMA and DHHS with regard to who actually selects those individuals and determines who will be deployed into those areas. With regard to the state coordinators, most disasters and public health and medical emergencies are local. The ESARVIT program provides each state with the ability to quickly identify, contact, and deploy health professional volunteers during disasters and public health and medical emergencies. Using a common set of standards in the ESARVIP registry, state coordinators facilitate the deployment of willing, needed, and qualified health professionals for any emergency. Who manages ESARVIP? Formerly, it was under the Health Resources and Services Administration, but ESARVIP today is managed by the Office of the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. ASPR assists with each state and territory in establishing a standard volunteer registration program. In the state of Nebraska, the ESARVIP program is managed by the Hospital Preparedness Coordinator within the Department of Health and Human Services, Division of Public Health. We currently are in transition with that position, but in the next week or so, that position will be announced and you will be referred to that person. With regard to registration and how a person can sign up, there is a website, a link that you can go to, which I have placed here. There is also a list of current licensed and credentialed health professionals, and those, if you're not considered in one of those professions, you can contact the ESARVIP coordinator, and they may be able to help you with regard to whether or not your profession can be added to the list or where you might fit in. There are 4 different credential levels to make the most effective use of health professionals who may have varying levels of clinical competency. The ESARVIP program has developed a uniform process for classifying and assigning volunteers into one of 4 credential levels, and this is based on the credentials provided and verified. Assigning healthcare volunteers to these different levels is important because it reduces the credential verification burden for emergency care delivery, allows personnel to be allocated according to need, permits volunteers to be used at their highest capacity, and facilitates sharing of volunteer personnel. Those 4 levels are categorized as level 1, 2, 3, and 4. Level 1 identifies volunteers who are clinically active in a hospital, either as an employee or by having hospital privileges. Level 2 identifies volunteers who are clinically active in a wide variety of settings, such as clinics, nursing homes, and shelters. Level 3 identifies volunteers who meet the basic qualifications necessary to practice in the state in which they are registered. And level 4 identifies those who have healthcare experience or education that would be useful for assisting clinicians and providing basic health care not controlled by the scope of practice laws. This may include health professional students or retired health professionals who no longer hold a license. With that, I would like to turn this over to Brianna Rooney. She would like to give an update on some grant funds that have come available with regard to combining the HON alert system and the ESARVIP system database.
Yes, so Nebraska's Health Alert Network system and ESARVIP, they're 2 similar systems. They're used for to share similar information about health professionals, and we'd like to merge them into a single system. And the new system will be coded using the latest web development standards and hosted on a redundant hardware for reliability, and that would be done by Kevin Kudo, who we use regularly for HON system updates and ESARVIP updates. And the updates will allow health professionals to log in, maintain their own demographic information, subscribe to relevant public health topics, and verify any changes on their volunteer profile. And they'll be able to do that themselves rather than using that antiquated process of mailing surveys to health professionals and manually entering the data. So further, both systems will be enhanced to interface with the Nebraska Department of Health and Human Services licensure data to provide additional automation for database management. And once these upgrades are complete, both systems will be tested for reliability and usefulness. And this will be done through those quarterly ESARVIP drills that we conduct at the State Health Department. And the goal for those quarterly drills are to have 80% response rate for those health professionals that call in and respond to whatever alert they get. Right now, we're not at 80% yet, so hopefully this merger will get us to that point for preparedness in the state of Nebraska. So thank you, Kathy.
Thank you. Thank you, Brianna and Kathy. My name is Denise Bulling, and I'm with the University of Nebraska Public Policy Center, and I'll be presenting information now on behalf of the Department of Health and Human Services State Disaster Coordinator, Ms. Michaela Johnson, and the Public Policy Center team. We work jointly to help put together the information and coordinate Nebraska's disaster behavioral health response. So Nebraska encourages all clinicians, mental health clinicians, to register with ESAR-VIP. But in fact, Nebraska Disaster Behavioral Health includes both licensed and non-licensed mental health personnel who have training at a minimum to deliver what we call disaster psychological first aid. Spiritual care providers, disaster chaplains, also work very closely with disaster behavioral health. In Nebraska, most of the volunteers of this workforce, both the spiritual care and the disaster behavioral health, are volunteers. Now, the state has a plan to guide the preparation, deployment, and coordination of services delivered by these volunteers. And as I mentioned, the volunteers may be registered on the ESAR-VIP system. They may also be part of the Medical Reserve Corps, which Ryan Lowry talked about earlier. The plan for Nebraska serves as a template for our regional divisions, which is the regional behavioral health authorities. And each regional behavioral health authority maintains a regional disaster behavioral health plan that's based on this state plan. These regions are multi-county, and they serve as the local network manager for publicly funded mental health and substance abuse services. You can find a copy of the state plan on the website on your screen. Go to disastermh.nebraska.edu and you can look under the resources tab. Organizing the behavioral health function is similar to and highly related to the organization of public health and medical response. Now, there are often multiple organizations responding to a disaster, and they each have their own behavioral health teams. So this can get confusing. We know that emergency management is the activation point after disaster for most disasters, except for that public health disaster. Local, state, and voluntary organization resources and plans should all be coordinated using incident command principles, ICS, and the National Incident Management System, NIMS. And behavioral health generally falls under public health. Thus, it's public health that must understand and activate us, we who are part of the disaster behavioral health response. Usually, this is part of what we call emergency support function number 8, or ESF number 8. It's the health and medical annex of an emergency operations plan. But behavioral health resources could also be activated under other emergency support functions like agriculture and mass care, or the function may be automatically part of a voluntary organization active in disasters, such as the American Red Cross or maybe faith-based organization. So the trick is knowing who has what resources active, where, and when. So ideally, we want behavioral health to be coordinated so these efforts aren't duplicated. So for example, the Red Cross mental health responds to Red Cross, but ideally there'd be coordination between health services for the Red Cross and the behavioral health person coordinating on behalf of state and local public health to make sure that these limited resources are deployed appropriately. This is a confusing slide, but in behavioral health, our workforce is very diverse. And this is the same in many parts of the country. And it's often staffed with volunteers who come from many different professions and sectors. So the table on this slide provides a simplified snapshot of the most common workforce sources. In many cases, the first formal organization on the ground after disaster with a behavioral health function is the American Red Cross. And the Red Cross uses only licensed mental health professionals to staff their mental health function. These volunteers are part of health services, and although they're present in all phases of disaster, Red Cross is most prominent in the early response phases and early recovery period. In large-scale disasters, you might see them active for longer periods of time. But unless it's a disaster that warrants a national designation with resources, it's likely that local Red Cross mental health resources are going to be exhausted very early. Red Cross Mental Health serves their volunteers and workers and the survivors that they come in contact with. Nebraska also has an organized critical incident stress management team, and many response organizations have individuals assigned to fulfill this role. CISM typically uses both mental health professionals and peers, and it can be active in any phase of disaster, but most often it's in the response phase. The Federal Emergency Management Agency, or FEMA, Crisis Counseling Program grant, crisis counselors are generally only available if the disaster is really big and it warrants a presidential declaration making that area eligible for individual assistance. If a state applies for and receives a crisis counseling program grant, there are mental health professionals and trained workers indigenous to the area that are available to help communities and individuals in that declared area during the recovery period. Now, everything else, literally everything else related to disaster behavioral health is the responsibility of the local jurisdiction. Local capabilities for disaster behavioral health, generally we say, should be able to cover a 72-hour period, hopefully giving other organizations a time to arrive if it's a large-scale event. Including the mobilization of state behavioral health resources like the State Behavioral Health Emergency Response Team for Disaster Behavioral Health. Local and state workers may use a combination of licensed professionals like social workers, counselors, psychologists, addiction professionals, and volunteers trained in psych first aid. And spiritual care providers often work in parallel to behavioral health. Again, in an ideal world, these volunteers would also be coordinated under the health and medical umbrella. There are often volunteers who arrive who don't have any formal affiliation and say, hello, I'm a clinician and I want to help. We call these unaffiliated volunteers. They go through the same process that all on-site volunteers complete. So if you identify yourself as disaster behavioral health somewhere in the process, we want them diverted to specialized just-in-time training for the delivery of psych first aid. And the person under health and medical charged with coordinating behavioral health should make that assignment, ensure they've completed training. This is the general layout of a volunteer processing center. Now, disaster behavioral health usually is identified during the interview and or in that next phase with the agency matching. If there's specific request for behavioral health volunteers, the person's license is checked and he or she is matched to that site. Now, depending on their assignment, they may also be required to attend the safety briefing, and all volunteers will receive an ID badge showing that they have the credentials to serve in their position. Volunteers who are affiliated with Red Cross or pre-credentialed on a regional disaster behavioral health team or a state emergency response team might already have their credentials. In that case, they may actually skip the volunteer processing center site and report directly to the staging area before they go to the disaster site. And multi-day volunteers may also be asked to report directly to the staging area after their process in the first day. Critical incident stress management teams are a little different. The Nebraska CISM team may only be requested by a response entity. So that request goes directly to the State Patrol, and they notify the CISM coordinator for that area. That coordinator assembles the team and provides deployment instructions. The team responds directly to the agency making that request, and they will not go through the processing center, and generally they won't even go to the staging area or the incident site. So that's a big difference in the way the CISM team versus other disaster volunteers are deployed. In very large disasters, there may be crisis counselors, as I mentioned. funded by a Federal Emergency Management grant to the state. And these counselors may be in communities for up to a year after a disaster. The regional behavioral health authorities may also send teams into communities to assist with recovery long after response operations are over and the volunteer processing center is shut down. So during recovery, crisis counselors provide information about stress reactions, phases of recovery, and they listen to volunteers tell their stories. Their primary focus is to assist survivors by connecting them to information, psychological and emotional support, and each other, because we know that connection is protection. Please feel free to reach out if you have additional questions. And again, the Nebraska State Disaster Behavioral Health Coordinator at DHHS is Ms. Michaela Johnson. I'd like now to turn it over to Mr. Daryl Klein, who is going to end our webinar with a discussion about the state plan and applicable legal authorities.
Hello, thank you very much, Denise. I'm Daryl Klein. I'm an attorney. I support the Public Health Division at Nebraska DHHS, and I'm going to be mainly talking about emergency response in a proclaimed emergency and in associated training with that, as opposed to a public health emergency, which is kind of a federal concept. It's both a concept and it's a legal structure that the feds have. However, in Nebraska, we're an all hazards response. So there may be instances where ESF 8, which is public health and medical, will take the lead. But what I'm mainly going to be talking about is an actually proclaimed emergency, which has to be proclaimed by the governor. And the request for that is routed through emergency management and also associated training. And just so you know where I'm coming from, I've actually served a couple stints at the ESF 8 desk back when the Emergency Operations Center was in the bunker. I had always assumed that lawyers would be used as sandbags in the event of an emergency, but apparently there was a need when the EOC was in the bunker. I think I was down there as a canary to make sure the oxygen content was okay. I am, as I say, a lawyer, but I'm not your lawyer, and I'm not the lawyer who supports Emergency Management Agency either. And that's kind of significant. We'll get into that a little bit later, but that all worked out. Those of you who have heard me in person know that I'm knowledgeable, funny, and extraordinarily humble. But since this is a virtual presentation, I'll just be virtually those things. Also, part of my bona fides, I've worked with volunteers before, and I found like training in herding cats came in very handy, and I do know how to do it. So going back to 2009 is when it really ramped up. We were looking at a lot of questions in response to the surge capacity requirements that the federal government and the states were making on hospitals, and also for ESAR VIP and the MRCs recruiting volunteers. We were getting a number of totally valid questions that took longer than it should have, but it seems like it was a long time ago to get the questions answered. So we put together kind of this FAQ, and the bottom line is we were asked a lot about liability protection and workers' comp coverage. The question is if the volunteers were covered under that, and the short answer is yes, provided that the volunteers are formally organized and their efforts are coordinated with and in support of local or the state emergency operations plan. And the question about whether or not there are liability protections is covered by the Emergency Management Act, in that Nebraska, like a number of other states, but not every state, actually includes volunteers in the definition of an emergency management worker. And that is significant because in the immunity from liability, there is an express set out that there's a liability shield, that this section of laws also shows that a license requirement can be suspended by the governor, and that mutual aid can allow cross-border practice, meaning folks who are credentialed in another state can come into Nebraska and in a proclaimed emergency practice here. And I want to point out to people, I'm using the word credential in the current sense of Nebraska's Uniform Credentialing Act, that's basically kind of a licensure from the state as opposed to having the privileges in a hospital. But at any rate, the functions provided for in the Emergency Management Act are declared to be government functions. And unless somebody is malevolent, stupid, or just evil, any emergency management worker following the plan is not going to be liable for the death or injury to persons or for damage to property. So that helps out a lot. There's a significant coverage there. If a volunteer is responding as part of the formal emergency response, that's pretty extraordinary protection there. And then in addition to that, our Nebraska Workers' Compensation Act, at the baseline, if you're an employee and you're hurt by accident or occupational disease in the course of your employment, you're entitled to compensation as long as you weren't willfully negligent at the time of receiving that injury. And that's significant for volunteers because, again, the workers' compensation statutes themselves include in the definition of employee not only members of the emergency management agency or a local response organization, but also any state emergency response team in which the agency organization is regularly organized under the laws of the state. And in those instances, if you're on one of those teams, you're deemed employees of the agency. And therefore, if you would be injured, you would be entitled to workers' compensation coverage. So a long time ago, again, 2009, these issues were coming up in response to our requests for hospitals to meet surge capacity requirements and for volunteer recruitment. And as I've mentioned, our Emergency Management Act in Nebraska requires a declaration. At the federal level for a public health emergency, the declarations can be a little bit different, but there needs to be a formal proclamation. And this will trigger suspension or waiver of legal requirements. We'll get into that in a little bit. It triggers the liability protections of the volunteers and other emergency management workers. Licensure requirements can be suspended, and cross-border practice is also made possible. And all of the states and territories are also signatories to the Emergency Management Assistance Compact, which also allows cross-border practice of professionals and also provides for liability protection and workers' compensation. The EMAC is triggered by a governor's declaration and a request for help from the other states. And then in, again, 2009, in response to some of these questions, this is a graphic of the Beacon, which is Nebraska Emergency Management's newsletter. And specifically in connection with exercise and training, the MRCs and the folks who were asked to join ESAR VIP put together a number of legitimate questions, and there was actually a meeting with the Lieutenant Governor as the Homeland Security head, Al Berndt from NEMA, Dr. Schaefer from Health and Human Services, and a number of others representing the MRCs. And this was driven by not really the MRCs, it was the MRSs at the time, which are now healthcare coalitions. And the question presented at that time was focused on volunteer training. And they sent a question over to the Attorney General's office so that we could basically clarify it, that it wasn't just Daryl's reading of the statutes, but let's get the top law enforcement officer of the state on board so that we had a common interpretation of the emergency management statutes. And part of what I didn't put up on the graphic, this, by the way, the quoted language there is from the actual AG's opinion. And then the language down below that is Al Berndt's comments in the Beacon. But the AG's opinion basically held that volunteer training or preparing for an emergency are activities covered by the Act. And the consequence of that is that the liability protections and the workers' compensation provisions also include folks who are training for an emergency. And that's significant because at this point there wouldn't be a proclaimed emergency. but we have a construction of the statutes that show that those protections do apply. Anecdotally, haven't checked this for a long time, but when we did look into any lawsuits that might have ever been filed in connection with emergency response, there seemed to be an indication that there are more people hurt in training exercises than in the actual emergency response, probably because people are goofing around like I would be and they fall off the gurney and land on some rebar. So when I do that, it'll be a question of whether I'm just willfully negligent or not. But the final point that Al brought up is that the volunteers in training and in an actual event are covered by the immunity from any damage they might cause and the workers' compensation. Do note that Al said that the responsibility for this would be for the empowering agency. So at the local level during training, the workers' comp issue probably falls on the local emergency management's workers' comp carrier. That's something that U.S. volunteers don't have to really worry about. So I mentioned EMAC, it's the same thing. I've probably said this 3 times, so I won't say it again. It's another layer of protection as well. So here's the interactive poll question. We're going to go ahead and use ESP to determine your answers. So think really hard what you believe is the correct response to this. I'll give you a minute. Okay, time's up. I think the correct answer is E, but who knows? Next slide, please. Okay, another aspect of the emergency management statutes that may impact volunteers, in addition to all of the stuff we've talked about earlier, is the act in Nebraska and in those states that are colored yellow or orange on the graphic. These are the states where the governor actually has the power to suspend, waive, or modify laws by a declaration or proclamation of emergency. And in Nebraska and these other states, both statutes and regulations can be suspended by the governor. There may be some aspects of this that would come into play in terms of scope of practice of volunteers. Again, if we have a proclaimed emergency, I think the other parts of the act that indicate you can practice without a license being required, and this ability to suspend these regulatory statutes actually will allow in some instances for an expansion of scope of practice. This was all theoretical when we were putting it out, but in subsequent emergencies, Superstorm Sandy, New York used a similar provision to increase the number of trained healthcare professionals to get a wider pool to carry out some acts that normally would have been restricted to a smaller group of people. So that may come into play, and that may affect to some extent a volunteer who's responding. The Institutes of Medicine got involved in response to some requests. There are a number of folks, healthcare professionals, that are concerned about standards of care and wanted folks to look into crisis or alternate standards of care in an emergency. Now, lawyers look at this, and we don't really think that, that there's a need for it, which I'll get into in a minute. But one of the stumbling blocks early on in the discussion of this is when you talk about crisis standards of care or altered standards of care, we were seeing a little bit of a disconnect. People took it to have different meanings, and there seemed to be a little bit of a split between healthcare facilities and healthcare professionals. But in any event, for healthcare professionals, which would be the bulk of the people who are coming in with volunteers, the concern is generally the care that's required to avoid malpractice liability. From a facility standpoint, it was typically looked at as use of scarce resources and having some sort of basis to determine how to allocate those scarce resources. So one of the problems with coming up with altered standards of care is that each emergency is going to be a little bit different. And to come up with a pre-existing altered standards of care is really, in my opinion, impractical. Maybe impossible, but certainly impractical. I don't think you could come up with a one-size-fits-all. So we at DHHS in the Division of Public Health in one of the amendments to ESF 8 of the State Emergency Operations Plan for both on the public health and the medical side. We took it upon ourselves. We wrote in a duty to identify what statutes and regulations may need to be suspended to adequately respond to an emergency. So we've pledged in writing to help out folks in that event. But back to the malpractice standard of care and why the lawyers aren't sure that this issue needs to be addressed. The standard that a healthcare provider owes to the folks they treat is the ordinary and reasonable care, skill, and knowledge that is ordinarily possessed and used under like circumstances by members of the profession engaged in a similar practice in similar localities. And that's at 44-2810 if you want to read it yourself. But the bottom line is the key is under like circumstances. So the standard isn't going to change, but since the circumstances may vary, the care that is possible to deliver may change. So my advice is to basically do your best. So my final slide is a copy of the actual H1N1 emergency proclamation. You're going to need to squint a little bit. Fourth paragraph from the bottom actually wrote that, excuse me, with Al Burnt in the anteroom to the governor's office. And it calls upon the chief medical officer and the Department of Health and Human Services to implement their plans. We were focusing mainly on the distribution of antivirals at this point in response to the flu, and also suspend statutes and regulations that would impede the state response. So although we were focusing on the antivirals when we wrote that up, later there was a question when McKesson was selected by the SNS and the CDC to be the distributor for the flu vaccine. Normally in Nebraska, you need to have a pre-licensure inspection for each of the warehouses or facilities that's going to be involved. And we have to do a worker's background check ahead of time. But we determined in the light of the H1N1 emergency proclamation that the governor had given the authority to the agency to suspend its regulations requiring these things. So it's pretty flexible. If we have an emergency proclamation, we'll try to tailor it to what we can foresee as being necessary. And in actual practice, the governor's office, emergency management, and public health cooperated and coordinated and achieved a flexible response. So with that, there's my contact information. If you have any questions, get a hold of me, let me know. As a state employee, I'm not allowed to accept gratuities. So if you were inclined to do that, I'd have to refuse it anyway. So thank you. I'll give it back.
Daryl, we do have a question, and that is with regard to, if you could stress a little bit more about the importance from a training and exercise perspective about, especially at the local level. I realize at the state level, we keep track of the call down list for the ESAR VIP and different call down lists and drills that we perform, but perhaps for this, from the perspective of training exercise at the local level, the documentation process, the way you are including volunteers in your training and how important that is to keep track of that for this liability issue with regard to the state law.
Yeah, and I think that you've telegraphed the answer there very well. I mean, it's to make sure that you get these protections which are available under the law. It's important that you coordinate with your local emergency response so that it's clear that the volunteers are part of the formally organized response team. So the better you document it, the better off you are. And something similar to that in crisis standards of care. I think and again, I can't give advice to the facility, but from what I've seen from what's happened in other states, particularly with flooding as a result of hurricanes, the litigation has focused on failure to plan. That's kind of like low-hanging fruit for the plaintiff's attorneys. It's like not what you did was wrong under the circumstances, but you didn't even foresee those circumstances and plan for it. So to the extent that you can anticipate what demands you're going to need and try to address how you're going to respond to them, I think you'll be in better shape. And then, of course, if you have to vary from the plan as quickly as possible after the crisis, document what led you to vary from your plan. And I think that would go a long way toward making sure you get these liability protections.
And if I could just add to that, perhaps taking more care in writing your after action reports with your improvement plans and documenting what Daryl said is how you are going to improve that in that progressive HSEEK model, which is very important as well.
Okay. Thank you very much. At this time, we're going to end the webinar. And should you have additional questions or issues, please contact someone at the Department of Health and Human Services, Mr. Klein, Ms. Bulkbeck, or Brianna. We can contact Ryan Lowry or me, Denise Bulling, should you have other questions. Thank you.